Hey there, and welcome. Today, we're diving into a skill that is absolutely fundamental for nurses, IV therapy. Now, it's one of the most common things we do, but don't let that routine fool you. Its simplicity can hide some pretty serious risks. So let's get on that on-ramp and really explore the protocols that keep our patients safe. So here's our game plan. First, we're going to talk about the IV superhighway to really get a feel for its power and its peril. Then we'll become cartographers, mapping out the territory for picking the perfect site. After that, we'll get on schedule, looking at the strict rules of IV maintenance. Then comes the really important fact, the critical warnings you can never, ever ignore. And we'll wrap it all up with the patient-first protocols that tie it all together. So let's kick things off with why IVs are just so powerful in the first place. Just picture the body's entire venous system as this massive, sprawling superhighway. IV therapy, well, it's our direct on-ramp, giving us immediate access and incredibly rapid transit. And that brings us to a really key question, right? What is the body's fastest delivery route for any medication? You already know the answer. It's intravenous. There is absolutely no way to get medications circulating through the whole system any faster. But, and this is a big but, that incredible speed demands incredible responsibility from us. You know, this slide just lays it out perfectly. IV therapy is a classic double-edged sword. The pros are obvious, right? Meds absorb almost instantly, we can keep a constant therapeutic level, and it causes less damage than some other routes. But the cons, they're just as serious. You're always risking fluid volume overload, infection, and infiltration. That's when the catheter slips out of the vein and fluid just floods the tissue around it. Okay, let's get practical. Knowing where and how to establish that on-ramp, well, it's everything. This is where we have to be really careful, mapping the territory to choose the safest and most effective path for our patient. And this table gives us a great breakdown of our two main options. For short-term therapy, we're usually using peripheral veins, you know, the ones in the arm, hand, or sometimes the foot. But for long-term needs, we have to go bigger with central lines, like a CVC or a PICC line, which get us into the body's larger, more central veins. This is such a simple statement, but it is so critical. You might see a big, prominent vein and think, jackpot. But hold on a second. That doesn't automatically make it a good spot. We have to look much closer, because not all veins are created equal, and choosing the wrong one can cause a whole lot of problems down the line. So, what are we trying to avoid? It all comes down to knowing your no-go zones. First, stay away from valves. They feel like little bumps in the vein. You also want to steer clear of a paralyzed arm because of poor circulation. Same goes for the arm on the side of a mastectomy, which has impaired lymph drainage. An arm with a dialysis fistula or graft, that's completely off limits. Also, be careful with the anterior ulnar vein because it's so close to nerves. And of course, just avoid fragile varicose veins and tough scar tissue. Okay, so the IV is in. Job's done, right? Nope, not even close. Once that access is established, the real work begins. IV therapy runs on a very strict schedule, and sticking to it is absolutely non-negotiable for keeping your patients safe. This timeline lays it all out for us. Those bags of IV solution, they've got to be changed every 24 hours to keep bacteria from growing. The IV tubing and the insertion site itself, the rule there is every 72 hours. And blood transfusion tubing, that's one and done. It's strictly single use every single time. Look, if there is one number I want you to burn into your memory from this whole section, it is this one, 72 hours. That is the gold standard for changing out both the IV site and the tubing to minimize, and I mean really minimize, the risk of infection. And this is a mindset you have to have. IV infusions are medications. Say it with me. They are medications. They aren't just harmless drips of salt water. Every single bag hanging on that pole requires a specific prescription from a provider detailing the type of fluid, the total volume, and the exact rate of infusion. All right, let's shift gears here, and I really need your full attention for this next part. We're about to cover the critical warnings, the absolute, unequivocal don'ts of IV therapy. Getting these right can prevent truly catastrophic outcomes. This right here is the single most important warning I can give you. I cannot say this any more clearly. You never, ever, under any circumstances, push potassium intravenously. It will stop the heart. It is instantly fatal, period. So let's lock in these 3 cardinal rules, these big no-nos. Number 1, we never push potassium. It must always be diluted and infused slowly on an IV pump.
Number 2, never add medications to bags of blood products or TPN, that's total parenteral nutrition. It can cause all sorts of dangerous reactions. And number 3, always check for medication compatibility before you even think about running 2 drugs through the same line.
Okay, for our last section, let's bring this all back to where it matters most, the patient. Because great IV care means you're adapting your technique and you're staying vigilant about safety for every single person you take care of. You know, our elderly clients often have very fragile, delicate veins, so we need to adjust our approach. Avoid using those tight tourniquets. They can easily damage the skin and the vein. You know what works great instead? A blood pressure cuff, just inflated to a low pressure. It's so much gentler. And please, never ever slap the arm to try and make a vein pop up. All you need is some firm pressure with an alcohol swab. These infection prevention rules are universal. They apply to everyone. Always use your personal protective equipment. Stick to that 72-hour rule for changing the site. And this is huge. Be an advocate for your patient. The second that IV is no longer medically necessary, fight to get it removed. Every hour it stays in is another infection risk. And if you break your sterile technique during insertion, just stop. Get a fresh catheter and start over. It's not worth the risk. So we're going to end